Hi, my name is Steve Smith, and I'm from Hennepin County Medical Center at Hennepin Healthcare and the University of Minnesota in Minneapolis, Minnesota. And I've been invited to give the Peter Ryland lecture. And that lecture is, let's replace the STEMI-NonSTEMI paradigm with the occlusion MI, or OMI, versus the non-OMI, or NOMI paradigm, the OMI-NOMI paradigm. I'd like to thank the International Society for inviting me. I'd like to thank my co-authors on several of these articles, and my Hennepin colleagues who've been an inspiration to me all these years. We do a lot of unfunded research here, and as all my research is, and I'd like to thank Scott Joying, whose recording studio makes this recording possible. I have no conflicts of interest. This is Hennepin County Medical Center. We have a wonderful place with lots of great teaching, lots of great patients, and research as well. And this is a paper that we published just this year in the Journal of Electrocardiology called STEMI, a transitional fossil in MI classification. A while back, we published the OMI manifesto. OMI is occlusion myocardial infarction, and NOMI is non-occlusion myocardial infarction. And there you can see Martin Luther pinning an EKG with hyperacute T waves on the door of the church. The ECG in emergency medicine. The diagnosis of occlusion MI versus other, especially rhythm, is far more important than any other aspect of the ECG. This is because when you have an abnormal rhythm, whether it's slow or fast or regular, you know you've got a problem. But when you have someone with chest discomfort, you don't know whether you have a big problem or whether it's just gastroesophageal reflux or chest wall pain or some other benign etiology, which make up the majority of patients with chest discomfort. Even most emergency physicians do not understand that they have this problem because they think that they only need to diagnose STEMI or not. They don't realize there's an intermediate category of OMI. Perhaps there's nothing new for all of you here, except to think about the data in a different way. And reframing is necessary. The name STEMI leads to cognitive bias. Cognitive frameworks or paradigms influence us. And all of us here in this society love ECGs, so let's celebrate it to its full potential, and not just one aspect of it, which is ST elevation. Let's look at the whole ECG. This is my blog, where I have hundreds of cases of occlusion myocardial infarction that do not meet STEMI criteria. This is one which an intern recognized. This is that electrocardiogram. You can see there are very symmetric T waves in V2 to V4. I can look at this and immediately know that if it's a patient with chest pain, that it's an LAD occlusion. And this intern, after reading many such cases, recognized it immediately too, and applied a formula I'll tell you about, which was positive, and he activated the cath lab. And at the cath lab, the artery was indeed occluded and was opened up and then fully opened with good flow. This patient came in with chest discomfort, and the computer said it's a completely normal ECG. Well, you can tell it's not normal. There are hyperacute T waves all across the precordium. There's ST elevation in AVL and depression in 3, which does not meet STEMI criteria, but is clearly diagnostic of an occlusion MI. So why do we depend on ST elevation? It is a surrogate for coronary occlusion. It's an ECG sign that myocardium is at imminent risk of irreversible infarction or cell death, yet remains viable and salvageable. Where does the data come from? The FTT meta-analysis published in Lancet in 1994 looked at all 9 studies that were placebo-controlled trials of thrombolytics from the 1980s, all 9 studies that had at least 1,000 patients, and that added up to 58,000. Patients were enrolled if they had suspected MI. Only 4 of 9 required ST elevation, which was very poorly defined. 5 of 9 had no ECG findings required. No trial specified the method of ST measurement. 38% had greater than 6 hours of chest discomfort. They used streptokinase primarily as treatment. Results? If ST elevation, poorly defined, was present, mortality for those who got thrombolytics was lower. If ST depression was present, mortality in the thrombolytic group was higher. If left bone branch block was present, without any subcategorization, the mortality was lower. The conclusion, ST elevation is the best way to decide on reperfusion therapy if, and only if, your ECG interpretation is crude, ST elevation poorly defined, left bundle, ST depression, or neither. What about less obvious ST elevation? What about ST depression, its location or number of leads? How about hyperacute T waves? Proportionality. We can't treat all left bone branch block with reperfusion therapy. Which ones need it? How about paced rhythm? How about pseudo-STEMI patterns? STEMI, a pathology which is defined by a test, ST elevation on the ECG? That makes no sense. ST elevation, any Any pathology is going to have multiple manifestations, and it's not going to go by any millimeter criteria. OMI, on the other hand, is not defined by a test. It's not defined by the ECG with specified ST elevation. It's defined by the underlying pathology. Is the artery occluded with imminent infarction, irreversible myocardial loss? The STEMI-NonSTEMI paradigm has what we call the no false negative paradox. If the ECG meets ST elevation criteria and there's an acute coronary occlusion, it's a true positive. If there's no occlusion, it's a false positive. If the ECG does not meet ST elevation criteria and there's no occlusion, it's a true negative. But if there is a coronary occlusion, it's not a STEMI because there's no ST elevation. You can't have a false negative. No false negative. The test is the definition, ST elevation. In OMI-NOMI, the outcome, occlusion, is the definition. The insistence on ST elevation, especially millimeters, obscures the diagnosis. Here's a patient who came in with chest discomfort and, to me, has an obvious inferior OMI. His old ECG was completely different, makes it more obvious still. Cath lab was activated, but the cardiologist said there is no, that does not meet STEMI criteria. I am not taking him to the cath lab. So he waited 24 hours until the troponins were very high and found a circumflex occlusion, which he put a wire through and eventually opened up. But that was 24 hours too late. The discharge diagnosis? Non-STEMI. Here's a patient with chest discomfort who has an obvious left anterior descending artery occlusion. Cath lab was activated. It was the daytime, so 5 cardiologists came down to the emergency department. They said, this is not a STEMI. The patient got a very delayed cath lab activation, and when he went, had 100% LAD occlusion with a very large MI and much myocardial loss. But it was not a false negative. The final diagnosis was non-STEMI. The ST elevation criteria in use today were published by Peter McFarland in 2004 in his landmark trial and are now incorporated into the 4th universal definition of MI. There were 1,220 patients, 248 with MI by CKMB. It was not an angiographic study. They looked at 2 consecutive leads with ST elevation and looked at 1 millimeter in all leads except V2 and V3, measured at the J point relative to the PQ junction, QRS onset, and V2 and V3 for women, 1.5 millimeters, for men over age 40, 2 millimeters, for men under age 40, 2.5 millimeters, and that was 46% sensitive for myocardial infarction as diagnosed by CKMB, but that would be a much lower percentage if diagnosed by troponin, because troponin diagnosed many more myocardial infarction. The denominator would be much larger, 98% specific. But the problem is, people have baseline ST elevation, or not, maybe. Is it baseline or is it ischemic? This patient came in with chest discomfort and has a tiny bit of ST elevation in V2 and V3. It looks normal, doesn't it? The whole EKG looks normal. And yet, this patient has no ST elevation at baseline, and this ST elevation represented an LAD occlusion. This patient came in with chest discomfort as well and has a little bit of ST elevation in V2 and V3, just like the previous patient. However, for this one, this ST elevation was his baseline. This patient's ECG looks no different than his baseline ECG, and yet he had 100% acute proximal circumflex occlusion, which we know benefits greatly from reperfusion, even though it doesn't show on the ECG. Here's another patient with 100% acute proximal circumflex occlusion that has a totally normal ECG, no ST elevation at all, even in V2 and V3. So you can't depend on ST elevation to either rule in or rule out OMI. Patients with STEMI who rule in for MI and are diagnosed with non-STEMI and go to the cath lab the next day, well, Kahn looked at a meta-analysis of these patients, 40,000 of them. At next day angiography, 25% had an occluded infarct-related artery without any significant collateral coronary circulation. They rarely had emergent reperfusion. They ended up with higher biomarkers than the non-STEMI patients who did not have an occlusion, worse LV function than the non-STEMI patients who did not have an occlusion, and a higher mortality than the non-STEMI patients who did not have an occlusion. That's the reference, and there are multiple others that are similar. Acute MI and OMI. Approximately 28% of acute MI are STEMI, 72% NSTEMI. All true positive STEMI are OMI. Of all OMI, about 60% are STEMI and 40% are not STEMI. They are the subgroup of non-STEMI that have occlusion, and we call them STEMI negative OMI. Of all acute myocardial infarction, then about 45% are OMI, 55% NOMI, 28% are STEMI, 17% are STEMI negative OMI. Greater than 25% of non-STEMI are OMI, and less than 75% of non-STEMI are NOMI. I want to make the point, too, that in the Kahn article, those arteries were occluded at next day angiogram, and we know that by by next day, many arteries open, so it would have been many more occluded at the time the ECG was recorded, when the patient presented with chest pain. So is emergent reperfusion therapy essential for STEMI negative OMI? Well, Koyama, back in 2002, did an immediate angiogram PCI for all suspected STEMI and non-STEMI. He took non-STEMI with persistent ischemic symptoms or ECG ischemia without persistent symptoms. These patients did not have to have persistent symptoms. Positive biomarkers were not necessary. They had to have ECG findings, though: ST depression, not reciprocal to ST elsewhere in the ECG, or non-diagnostic ST elevation, or T-wave inversion, or no ST segment deviation at all, or peaked hyperacute T waves. STEMI, 50% had TIMI zero flow, 100% included. Non-STEMI, 40% had TIMI zero flow. So the angiographic state of these two supposedly different entities is not very different at all. The mortality was 5% in both groups. Hillinger, just in 2019, looked at consecutive patients with chest pain and did a prospective validation of current quantitative electrocardiographic criteria for STEMI. He looked at 81 retrospectively adjudicated STEMI and 136 OMI. And I'll show you the flow sheet here. There were 2,500 suspected ACS, 438 acute MI, 302 of which were non-occlusion, 136 had occlusion, 41 had STEMI as diagnosed by STEMI criteria, by measurements. 81, however, were retrospectively adjudicated as STEMI by cardiologists looking at the case. If you look at these two columns over here, STEMI and OMI, computer using STEMI criteria diagnosed STEMI 35% of the time on the first ECG, 21% of OMI. If you use serial ECGs, the sensitivity went up to 51% for STEMI, 30% for OMI. A blinded cardiologist using visual ECG interpretation was much better for finding STEMI and OMI, but still found only half of occlusion myocardial infarction. We wrote an editorial on that called Prospective Real-World Evidence Showing the Gap Between STEMI and OMI. But are OMI really similar to STEMI? Maybe they're just a lot smaller myocardial infarctions. So we published this last year in the Journal of Emergency Medicine, Comparison of the STEMI and OMI-NOMI Paradigms of Acute MI. And we found this. So we used troponin as a measure of infarct size, peak troponin. These are all OMI. These are all STEMI. They're about the same. These are STEMI negative OMI. They are slightly smaller, but not statistically significantly so. Then you look at non-STEMI, much smaller, and NOMI, much smaller still. Remember that non-STEMI are divided into STEMI negative OMI and NOMI. You can see that those non-STEMI who are not occluded are far different from those who are occluded, and these have very large MIs. Now, these did not get acutely reperfused because that's not the management style for non-STEMI, but you can imagine that they would do better if they were immediately reperfused. How about high sensitivity troponin T? Will that identify OMI? Well, looking at the Hillinger group, again, they reported to me personally in their group of patients, 136 OMI. The first initial HSCT&T level was less than 5 and 1. It was less than 14 and 8%, and it was less than the European Society cutoff, which has a good positive predictive value for MI of 52. It was less than that 52 in 40% of cases. How about high sensitivity troponin I? Well, we published this in JAMA Cardiology last year, looking at 925 patients with STEMI, and 2.2% had an initial HSCT&I less than 5, 14.4% had it less than the URL, and 27% had it less than the European Society cutoff of 52, which is the best, a good cutoff, which has a good positive predictive value for myocardial infarction. However, the ECG can identify OMI. This is the difficult study by Oslinger et al., and I was on that as well. 28% of NSTEMI could be reclassified looking at the ECG blinded later, could be reclassified as OMI by expert ECG interpretation. So this is the results here. You can see on the left, these are controls, 1,000 controls without MI, 1,000 non-STEMI, and 1,000 STEMI. And as time goes on, STEMI have higher mortality than non-STEMI. But if you take all those non-STEMI and look at their ECGs and classify them as non-OMI or OMI, you can see that the non-OMI do not have very high mortality, whereas the OMI have mortality that's not statistically different from the STEMI over time. Again, in another study, which I'll show you, experts can identify OMI on the ECG. We looked at 808 patients in a case control study. 412 had MI ruled out, 265, excuse me, had OMI, 131 NOMI, and we looked at serial ECGs on all these patients. So I ended up reading 3,421 ECGs. We published it in Circulation as an abstract and is in press now at the International Journal of Cardiology, Heart and Vasculature. And this is what we found. Depending on how you it's difficult to define occlusion myocardial infarction. You can't just define it by the angiogram alone, occlusion, because as many people don't know, 20% of true STEMI have an open artery at angiogram because the time between the EKG and the angiogram is significant and arteries do open. Take people that had true STEMI, their arteries occluded at the EKG when they present. By the time they get to angiogram, 20% are open. So we have to use a different outcome criteria, and we use, our primary was TIMI 02 flow or TIMI 3 flow with a culprit that's intervened upon and a very high troponin, meaning a troponin I greater than or equal to 10 nanograms per milliliter or a troponin T greater than or equal to 1.0 nanograms per milliliter. There's a lot of data behind those choices, and I'll tell you a little bit more about it later. My sensitivity for OMI so defined was 86%. The STEMI criteria only 41%. My specificity 91%. STEMI criteria 94%. Accuracy 89% versus 77%. If you take a more liberal definition of OMI, don't require the troponin to be so high, my sensitivity goes down. As they're smaller MIs, it's harder to detect by EKG. Criteria goes way down as well. Specificity gets better, and accuracy gets far better in that case for expert interpretation over STEMI criteria. The STEMI criteria were measured by a third interpreter cardiologist, and they were even less sensitive. When we measured the STEMI, we classified more OMI as STEMI than this cardiologist did. So that even adds to our conclusions. The results were same for expert 2, excuse me. When STEMI and OMI criteria both diagnosed OMI, OMI criteria diagnosed OMI a mean of 3 hours earlier than STEMI criteria, or a median of 1.5 hours. So we're getting to the cath lab faster when we use OMI criteria. What are those OMI criteria? 7 findings. Hyperacute T waves, 49%, pathologic Q waves along with subtle STE, 47%, terminal QRS distortion, 53%, reciprocal ST depression and or reciprocal T wave inversion, 82%, subtle STE not meeting criteria but with other features, 83%, any amount of STD maximal in V1 to V4, 45%, any STE in inferior leads, 50%. This adds up to way more than 100% because most OMI have multiple findings on each ECG. Multiple subtle findings, none of which are STEMI criteria. And you can see how we add several features of the ECG in here. This is a study I did back in 2012 and several studies following up on it. We looked at benign ST elevation in leads V2 to V4 and compared it to those with LAD occlusion and came up with a 4-variable formula using angiographic studies. All patients enrolled had to have 1 millimeter of STE in at least one of leads V2 to V4. We found that corrected QT interval and validated was one of the important variables. The ST elevation at 60 milliseconds after the J point in lead V3, R wave amplitude in V4, and total QRS amplitude in V2. We derived a formula and validated it. It was externally validated, and then a simplified formula was developed which uses uncorrected QT. And here are all the articles where those formulas are discussed. The results of the external validation found that the diagnostic utility at the most accurate cut point had a sensitivity of 83%, specificity 88%, accuracy 86%, and this was compared to the universal definition of MI STEMI criteria, which had only 22% sensitivity for LAD occlusion. 97% specific, however, accuracy was only 66%. And so Ostlanger, the author of this article, said in a tongue-in-cheek way that it should not be called STEMI, it should be called a small QRS MI. So I saw this in a pile of ECGs once, and I thought to myself, oh my God, if this patient came with chest discomfort, this is an LAD occlusion. And so, why did I think that? These T waves are too symmetric to be normal. There's reverse R wave progression here. And this alone is enough, but in addition, there's downsloping ST depression with a down-up T wave and 3 in AVF. So this is probably a proximal LAD occlusion. I went to the chart and found out that indeed the patient did come in with chest pain. Indeed, they did not recognize this as abnormal. So they drew a troponin, and the first troponin was negative. So they admitted the patient. They got a repeat troponin at 4 hours, and it was positive at 3.8. So they did a repeat ECG, and now you can see that there are deep QS waves throughout the precordium. All the anterior wall is dead. the patient went emergently to the cath lab at that point in time. And by the way, the formula I just talked about would have been positive. Patient had full LED occlusion. Peak troponin was 140 nanograms per milliliter, which is a huge myocardial infarction. And there was a convalescent echo with an anterior wall measured anomaly and ejection fraction of 40%. So a lot of myocardial loss. We should be aware of dichotomies, even the OMI-NOMI dichotomy. Every pathology has a spectrum of severity. As you all know, if there's partial ischemia, the subendocardium is most vulnerable and gets ischemic, and the overlying lead can have ST depression then. Or if there's full thickness ischemia, the overlying lead has ST elevation. But both of these are due to thrombi in the coronary artery. And thrombi, as we know, lyse and propagate over and over. Any thrombus that's partially occluding can become a fully occlusive thrombus. So this is a 60-year-old male with chest discomfort. He came in with lots of ST depression, clearly has an acute coronary syndrome, has a thrombus in either his LAD or his left main. Because there's no ST elevation, he was not treated with emergent reperfusion. He was given aspirin and enoxaparin, and he was given lots of morphine, so his pain went away. Indeed, his pain did go away with morphine. But when they repeated the ECG 12 hours later, his anterior wall was gone, the thrombus had propagated, he lost his entire anterior wall and needed a heart transplant. This patient came in with flash pulmonary edema and had very elevated blood pressure. It was thought that this was pulmonary edema, and there's lots of ST depression here. It was thought the ischemia was due to only hypoxia and elevated blood pressure. So they treated him with positive pressure ventilation and high-dose nitroglycerin, and he got all better. And it didn't occur to them that perhaps the whole thing was initiated by acute coronary syndrome, which it was, and so they didn't get a repeat ECG until many hours later when it showed this, which is an obvious STEMI with right bundle branch block, left anterior fascicular block, a very high-risk MI where he might have died, but fortunately did not. So, you know, the old paradigm was non-Q wave MI and Q wave MI, and then it evolved to the STEMI-NonSTEMI paradigm where ST elevation can evolve into either of these and non-ST elevation can evolve into either of these. We forget this, and we should forget this paradigm, and this paradigm hopefully will be forgotten as well. Acute MI is a spectrum. STEMI on one end, mostly high risk based only on ST elevation, or non-STEMI without high risk features on the other end. But in the middle, there's those with absence of ST elevation criteria but are at high risk for death or large MI. STEMI and non-STEMI are actually, non-STEMI has a higher one-year mortality than STEMI. This is just one study, D'Souza in 2015, where he found that one-year mortality for STEMI was 14%, 27% for non-STEMI, 5% for unstable angina, and at 3.2 years, there was 45% mortality for non-STEMI. Now, there are many reasons for this. Sometimes they're just baseline sicker patients. But I believe one of the reasons for this is that the non-STEMI have occluded arteries that are not being opened. How about ST depression? This was studied in ISIS-2, GISI-1, late, and TIMI-3B. And they found no benefit of fibrinolytics. However, studies enrolled patients who had as little as 1 millimeter of ST depression in only one lead, small numbers of patients, and very few were enrolled less than 6 hours. And we know if you open an artery after 6 hours, it doesn't make much of a difference, a little bit only. Hard to show a difference. For 25 years, fibrinolytics were contraindicated in ST depression, except in posterior MI. ACC/AHA 2013 STEMI guidelines add, except when associated with ST elevation in lead AVR. European Society of Cardiology says the optimal timing of PCI and non-ST elevation ACS has been studied extensively. However, patients at very high risk, refractory angina, severe heart failure, life-threatening ventricular arrhythmias, or hemodynamic instability were not included in RCTs in order not to withhold life-saving treatment. Such patients may have evolving MI and should be taken to an immediate, less than 2-hour invasive evaluation, regardless of ECG or biomarker findings. ACC/AHA guidelines say the same thing. Refractory angina should go to the cath lab within 2 hours. Also, hemodynamic instability, electrical instability, and worsening heart failure. Most common objection to the OMI-NOMI paradigm is, well, refractory ischemia is already in the STEMI paradigm. Well, the guidelines are not followed. In that big study by Kahn, 25% of 40 NSTEMI patients with occlusion were not recognized and immediately treated. And they did not have collateral circulation accounting for that. All of these patients were from academic centers, purportedly excluding patients with persistent symptoms or instability. And they had a 1.67 adjusted relative mortality risk compared to non-OMI. Conclusion is either all these doctors were mistaken and included patients with refractory ischemia, or refractory ischemia is inadequate. This paradigm does not work in the real world or even in the research world. Finally, we have found that many patients with persistent OMI on ECG do not have persistent chest pain. Here's an anecdote where the guidelines are not followed. This patient had OMI on his ECG, cath labs activated, cardiologist said, no, it's not a STEMI. Recommendations follow. And these are actual text messages from this cardiologist, back and forth. Chest pain 5 out of 10 still, BP, etc. Do you want me to go up to 20 mics per minute on the nitro? Yes. Order more morphine. Non-STEMI. Troponins greater than 25,000. Morphine given. Chest pain down to 3 out of 10 now. He's treating a myocardial infarction with morphine. That'll make anybody's pain go away no matter what. Needs med rec done. Complete. Next text message. We would like your opinion. I don't think it's a STEMI. Any further recs? No. And this is typical of, from all the anecdotes I get from around the world, this is very typical. And there are no studies on this because I don't think many people want to report how many OMIs they ignored. Most common injection number 2, NSTEMI trials of early versus delayed cath did not show any difference in outcomes. Well, the biggest of these was the TIMEX study, Time of Intervention in ACS, by Mehta. Non-STEMI were randomized to earlier routine PCI. There were no differences in outcome of death, MI, or stroke, unless the patient had a GRACE score greater than 140. Early, however, was not early. It was a median of 16 hours. If you open a occluded coronary artery at 16 hours, you have not treated the patient well. The methods do not mention refractory ischemia, although my personal communication with Dr. Mehta, he said, I doubt investigators would have enrolled patients with ongoing chest pain in this non-STE ACS trial. In a more recent study called the Verdict trial, the GRACE score greater than 140 was confirmed. In that study, they also excluded patients with persistent symptoms, and they had a median time to cath for the non-STEMI group, for the early intervention group of 4.7 hours, which still is not early enough. These are all the trials of very early versus delayed PCI for non-STEMI, and I will just summarize them here. If you want, I'll show you that so you can have a little more time to pause it and go over it if you want. But here you can you see a summary of them. The negative trials excluded refractory ischemia, or they had early. Early meant 5 to 16 hours from presentation. Well, that is not early. The positive trials, refractory chest pain was included, and early was defined as less than 2 hours. So non-STEMI patients who have symptoms and you take them right away, they benefit from that. Riddle NSTEMI is the most recent of these. 323 non-STEMI randomized to 2-hour PCI versus less than 72 hours. And the results, it was 1.4 hours for the rapid group, 61 hours for the slow group. They excluded persistent symptoms or instability. The patients they took had ST depression or T-wave inversion and greater than or equal to 1 millimeter or greater than or equal to 2 leads. And 30-day death or MI was much lower in the group they took emergently, 4.3 versus 13.0. 1 year, much lower in the group they took emergently, 15% versus 33%. Conclusion, even if no persistent symptoms, persistent ischemia is an indication to go to the cath lab without ST elevation. Most common injection number 3, but STEMI gives us something easy to teach. Well, can interventionists accurately diagnose STEMI? Tran had 84 cath lab activations, showed the ECGs to 7 experienced interventionalists, and asked emergent PCI or not. Recommendations for immediate PCI ranged from 33% to 75%, sensitivities 53 to 83%, specificities 32 to 86%. Terrible inter-rater reliability. McCabe et al. Published a similar study. 36 ECGs with occlusion, STEMI or not. STEMI was less than TIMI-3 flow. Other TIMI-3 flow could be non-OMI. 124 physicians got these ECGs. Inter-rater agreement was terrible at 0.33. Sensitivity for true STEMI, 65%. Specificity, 79%. 9 interventionalists were the best, but their overall sensitivity was only 70%, 89% specific and 76% accurate. I took the test myself and had 92% sensitivity and 100% specificity. So far better than the interventionalists. And I say this not to brag, but I say this to say that it's not the ECG that is nonspecific. It is the interpreter who is nonspecific. And you can learn to do this if you understand the principles. You can do this yourself. You Google STEMI test and you can take this test yourself. How about transient STEMI? Well, there's a randomized trial about that. Immediate, 0.3 hours versus delayed, 22.7 hours. 142 patients who had transient STEMI. Outcome equal. Conclusion, no difference. However, 4 patients in the delay group had to be taken in the middle of the night for reinfarction. Is that really no difference? People had to pay attention to those patients and take them. So I would disagree with the conclusions of that trial. Here's a patient with chest discomfort. It's resolved. And sure enough, there are Wellens waves here. Wellens syndrome looks to me like he had an LED occlusion when he had chest discomfort. Now it's resolved. Now he has reperfusion T waves. The artery is open. It was not seen by the clinicians. However, the troponin returned positive. And because the troponin returned positive, they got another ECG. And here it is. The patient has reoccluded, has pseudo-normalization of T waves and ST elevation, has an acute STEMI right now, but was asymptomatic with it. This is what I'm talking about with transient STEMI. This can happen with transient STEMI, and you have to be extremely vigilant if you don't take these patients to the cath lab right away. Who should undergo emergent angio, PCI, and ACS? OMI on the ECG, refractory ischemia, persistent ischemic ECG, persistent chest discomfort, without morphine until committed to the cath lab. Morphine just hides the symptoms. And we actually have shown in a study that giving morphine is associated with higher mortality. Electrical instability, hemodynamically unstable, pulmonary edema, or a hot thrombus, as I just showed you with transient STEMI. Better ACS dichotomy, persistent ongoing refractory ischemia or risk thereof, meaning persistent ischemic ST depression or ischemic symptoms, ECG evidence of OMI or dangerous thrombus, diagnosis based only partly on ST elevation. It's also based on the presence of persistent symptoms or the ECG with OMI, ST elevation, ST depression, T waves, the QRS, including R waves and S waves, previous ECGs, serial ECGs, echo, biomarkers, CT coronary angiogram, and angiography. Everything goes into the diagnosis of OMI, not just ST elevation, versus absence of persistent ongoing refractory ischemia. What are some conditions between STEMI positive OMI and NOMI, meaning STEMI negative OMI or active coronary thrombus? There's non-diagnostic ECG, but the patient has a positive troponin and ongoing symptoms. Subtle but diagnostic ST elevation, hyperacute T waves. And this does not mean just tall. Hyperacute T waves are bulky, wide, they look fat. STEMI equivalents, the modified Scarbosa positive, or De Winter's T waves, or posterior MI. Dynamic ST segments and T waves. Isolated persistent ischemic ST depression. Isolated persistent typical refractory angina, even if the EKG and troponin are negative, as the European Society of Cardiology recommends, even in the absence of ECG or biomarker abnormalities. Confusing are pseudo-STEMI patterns and demand ischemia, which can cause positive troponin and mimic an acute MI, but all be due to hypotension or anemia or tachycardia or what have you. Another false dichotomy is activate the cath lab or don't activate the cath lab. There's a middle way, and this is what we've instituted here at Hennepin County Medical Center. Our cardiologists here are totally on board with this OMI-NOMI idea, and they realize there's a middle group where it's not so easy to figure out if there's an occlusion or not. And we have multiple modalities to help figure that out, including serial EKGs, stat echocardiogram, CT coronary angiography, to find that out. We should activate the cath lab if there is an acute thrombosis in a coronary artery causing persistent ischemia that is refractory to medical management, or high risk of recurrent ischemia from active thrombus. One principle to remember is proportionality. T waves and ST elevation are only large or small relative to the QRS. Take this ECG, for instance. It's a 45-year-old woman with chest pain. There's not very much ST elevation, certainly not enough to meet STEMI criteria, but notice the QRS is very small. Well, let's stretch out that QRS. Let's make it a reasonably normal size QRS. Now there is a ton of ST elevation. It's the ST elevation to QRS proportion that matters, not the ST elevation itself. And if we'd used the formula on that ECG, it too would have been positive at 21.1. The most accurate cutoff is 18.2. Here's a patient with acute chest discomfort, and he has QS waves throughout his precordium. And some people would say, oh, this is an old MI with there's a tiny bit of ST elevation, an old MI with persistent ST elevation. But we've shown before that old MI with persistent ST elevation, we've shown a derivation and a validation, does not have big T waves. In fact, if there's a T to QRS ratio in any one of V1 to V4 that is greater than 0.36, it is an acute MI. And this indeed was an acute LAD occlusion with, again, barely any ST elevation. Proportionality was also important in diagnosis of OMI in left bottom branch block and pace rhythm using the modified Scarbosa criteria. Sgarbossa criteria is one lead with concordant ST elevation of 1 millimeter, or concordant ST depression in V1 to V3 of 1 millimeter, or discordant STE greater than 5 millimeters. However, this absolute number here doesn't make sense. Some QRSs in V1 to V3 are large, some are small, and it's the proportion that matters. So we modified the criteria. We said it had to be discordant STE of at least 1 millimeter and an STS ratio of 20 to 25%. 20 is slightly more sensitive, less specific. 25 slightly more specific, less sensitive, but both are good ratios. And that was shown to be superior to the old Sgarbossa criteria, greatly superior in all cases. In the left bundle branch block, derivation, validation, and ventricular pace rhythm, which is in press at Annals of Emergency Medicine right now. ECG challenges. Defining hyperacute T waves. Are they defined by bulk, amplitude, upward concavity, width, QT interval? How about right bundle branch block and ST depression V1 to V3? How much is too much? How much is too little? How about new right bundle branch block with left anterior fascicular block and chest discomfort, which Wydymski described as a very high risk presentation? How about ST depression location? 2-3 AVF only, V1 to V4 only, V5 to V6 only. We actually are about to publish a paper on ST depression in V1 to V4 only, which is very specific for posterior MI. Posterior meaning the old definition of posterior before bias de Luna. And using these to differentiate non-occlusive ischemia from OMI. There are probably many more I'm missing, and other literature I'm missing. How about pseudo-STEMI patterns? Well, we talked about left bundle branch block and pace rhythm. We talked about anterior LV aneurysm and T-wave size. LVH can be difficult with ST elevation V1 to V3 and a very deep S wave. The Armstrong 25% rule, which was published a while back, doesn't work, and their methodology was not appropriate in my view. I've also found that when I try to study this, it's very difficult to find patients who have high voltage S waves in V1 to V3. It seems that LAD occlusion diminishes the size of that S wave, but that needs more study. How about old inferior MI, otherwise known as inferior aneurysm? This is very difficult to differentiate from acute inferior ST elevation, and I have not found a good way to do so, except the size of the T wave appears to be one way. Myocarditis can very frequently be impossible to differentiate from acute MI. Pericarditis is, it may not be difficult, but the incidence of pericarditis is so low, the pretest probability is so low, that I've seen so many cases of pericarditis, of OMI misdiagnosis pericarditis, that I say that you diagnose pericarditis at your peril. Takotsubo can be, when there's ST elevation on the Takotsubo, can be nearly impossible to differentiate from acute coronary occlusion. But we need more research on these. There are papers published on all of them. None of them give any definitive answers. Research challenges. Defining occlusion. What's a good OMI research definition? I talked about this briefly before. You can't use the angiogram alone as a research definition of occlusion because the ECG and the angiogram are always done at different times and the coronary artery is dynamic. So you may have a full occlusion at the time you get the ECG, and then by the time the patient gets to the angiogram, the artery is open. How do you know, when you're looking backward and trying to find ECG characteristics that define occlusion, you don't know whether the patient had an occlusion or not. You have to find some surrogate way of figuring out whether that patient had occlusion at the time the EKG was recorded. What we've used is peak troponin for that. As I said, and why is that? You can't use angiographic occlusion only, and this is really solid evidence for that. If you take true STEMIs and do an immediate angiogram, Karwowski showed that 64% have TIMI 0 flow, 36% have flow of 1, 2, or 3. Stone showed 72% TIMI 0, 1 flow. In other words, 28% have TIMI 2 or 3 flow. Cox showed 80% TIMI 0, 1, or 2 flow. So 20% of these patients who have true STEMI have TIMI 3 flow by the time they get to angiogram. So you can't use the angiogram to define occlusion. It has to be something else. And if you hold OMI to a different standard than STEMI, that would be unfair. So that's about 20% of TIMI 3 flow. And it's a much higher percent if you look at the angiogram the next day, because many more arteries would be opened by the next day angiogram. So the OMI definition for our studies was based on a number of studies of troponin T and troponin I and STEMI versus non-STEMI. The modified Sgarbossa criteria in LVBB and paced rhythm, which was 3 studies, we used TIMI 0, 1 flow or culprit with a highly elevated troponin, 4th generation I, greater than 10, fourth generation T greater than 1.0. For DOMI Arigato, which was our study we're just about to publish on OMI, we used TIMI-02 flow or a culprit with a highly elevated troponin, using the same troponin definitions. The difficult trial was similar, TIMI-01 or culprit. In this case, Dr. Oslanger used troponin I greater than 5 nanograms per milliliter. And these are the 5 studies for that. High sensitivity troponin T was just studied in Clinical Cardiology 2018. They found that a high sensitivity troponin T value of 1,006 nanograms per liter best predicted the presence of acute total occlusion with a sensitivity of 86%, specificity 95%, PPV 86%, NPV 94%. HSCT&T of 1,006 is basically the same as 1.0 nanograms per milliliter. And this is the level that we have been using in our research all along. So this study supports, again, like previous studies do, our use of 1.0. Here's our OMI definition in DOMI Arigato. I showed you some of these columns before. Accuracy of proposed OMI criteria versus STEMI criteria for diagnosis of acute coronary occlusion in myocardial infarction. You could have very strict criteria. It has to be TIMI-01 flow or culprit plus a peak troponin I of 10 or peak troponin T of 1.0, in which case our OMI criteria are 90% sensitive, STEMI criteria 44% sensitive, and specificity is 88 and 94. If you have much looser criteria, you only require a troponin I of 1 or a troponin T of 0.1, then your ECG sensitivity goes down, ECG specificity goes up. For both STEMI criteria and OMI criteria, accuracy gets the difference in accuracy is much greater when you have a looser definition. Reviewers' objections to these studies, and this is many cardiology journals, JACC and European Heart Journal and American Journal of Cardiology and American Heart Journal, you need a TIMI-0 outcome. Well, I just showed you why a TIMI-0 outcome doesn't work. STEMI are not held to that standard. STEMI don't have a TIMI-0 outcome. Only 62% of them do. You need a STEMI outcome. Well, you can't have a STEMI outcome if you're studying left bundle branch block. There is no definition of STEMI. You need acute MI outcome. Well, acute MI does not measure occlusion. The vast majority of acute MI are not occlusion. They're small infarcts that have an open artery. You need a randomized trial. Well, a randomized trial has to be far too big. I certainly don't have the resources for that. And to do a randomized trial, you need people who sponsor it. You have to have something that they can sell. Well, they can't sell the EKG. It's too cheap. It's been around for 100 years. You need consecutive cases, not a case control. That's the same problem. You can't get that many cases. It takes too much time. Case control is what we can do, and it's very powerful. All patients need an angiogram. Well, all patients don't get an angiogram. If they rule out for myocardial infarction, if it's obvious they don't have a myocardial infarction, there's no need to do an angiogram. So for instance, in our left bundle branch block and ventricular paced rhythm studies, many of those patients, we say, did not have an occlusion because they had no MI at all. And yet the reviewers want an angiogram on them. Should only compare patients who all had an angiogram. Well, that's the same problem. You can't get an angiogram on them all, and you don't need an angiogram on all of them. Research challenge, classifying ECG morphologies as OMI or not. How about training a neural network? A research diagnosis of OMI on the ECG requires evolution. Why is that? Say the patient has a baseline non-ischemic ST elevation like LVH or normal variant STE, etc. Now the patient has a non-occlusion MI, low troponin, TIMI-3 flow. The ECG could be erroneously classified as OMI because there was some ST elevation, non-ischemic ST elevation there. The neural network would then be trained with an inaccurate ECG. How do we know whether that ECG which had ST elevation is truly an OMI ECG? How do we know whether that ST elevation represented ischemia or not? We either use an identical prior ECG or we use evolution. All ECGs manifesting ischemia will evolve. If that ST elevation was due to ischemia, it will resolve. The T waves will invert. Something will change on serial ECGs. So we have to keep that in mind. More research challenges, comparing STEMI to OMI paradigms. Well, it's hard to do a randomized trial. If I diagnose an OMI on an EKG, I can't randomize someone to wait 24 hours for their angiogram. I want to get that artery open now. It's not ethical to keep them, to not activate the cath lab. So maybe you can compare different management styles. Maybe one hospital uses an OMI-NOMI paradigm, the other another hospital uses a STEMI-NonSTEMI paradigm. You can compare their outcomes if you can match the patients. But that's very difficult to do as well. Or you could do a before or after in a hospital. They use the STEMI-NonSTEMI, and then they change the OMI-NOMI, and maybe you can compare outcomes that way. You need thousands of STEMI negative, OMI positive patients to show a mortality difference. So for that reason, you need surrogate outcomes like infarct size. But that's difficult to measure accurately. You need, for instance, ejection fraction. Well, ejection fraction in the acute phase doesn't tell you how much myocardium is lost. It just tells you how much is stunned. You need a 2 to 6 week echocardiogram to find out what the convalescent ejection fraction is, which correlates well with myocardial loss. MRI is good, but very expensive. Very few patients get it. Again, the timing of when you get that echo. Troponin is a pretty good measure of infarct size, but not perfect. Modalities now and in the future. Expert ECG interpretation, including previous ECGs and serial ECGs. Deep neural networks have a great future in this. We need to train them adequately. Echocardiogram has little research so far, especially point-of-care cardiac ultrasound. But even formal bubble contrast echo has little research on its sensitivity and specificity for acute coronary occlusion. We believe it's very high, but we're not certain. Troponin, CT coronary angiogram in acute coronary syndrome was studied as part of a sub-study of the VERDICT trial and showed very good positive predictive value, sensitivity, and specificity compared to angiography. And then if you don't know whether a patient has an OMI or not, it's very safe to take them to angiogram. It takes some resources, but unlike intervention, it has very few complications. Future research, deep neural networks. Do we train these by experts? In other words, do we train them by having the expert interpret the ECG and then teach it to the neural network? Or do we have to have real outcomes for every ECG? And which outcomes do we use? And you need thousands of OMI and thousands of controls with digital ECGs all accurately coded in order to train the deep neural network. The ECG in emergency medicine, what is most important? Rhythm disturbances, you know there's a problem. It's fast, slow, or irregular. Chest discomfort, OMI is a needle in a haystack. Most chest discomfort is non-cardiac. Occlusion is only present in 2 to 5% of ED patients with chest discomfort, and STEMI in only 1 to 3%. Only 1 to 2% have STEMI negative OMI. So you don't know you've got someone who's got OMI unless you're really good at seeing that ECG. STEMI negative OMI is hidden, not recognized. Here's an interesting case report that some colleagues of mine tried to submit. There's a 52-year-old with sudden chest discomfort. And they saw this ECG and were quite accurately concerned about an acute LAD occlusion with large T waves in V3 and V4, and with some inferior ST depression here. This was the pre-hospital ECG. 20 minutes later, it was this, and it looks like some evolution, especially inferior here. They were very worried about acute LAD occlusion. So they activated the cath lab, and the interventionist refused to take the patient until the patient went into cardiac arrest, at which time he was taken and the patient had 100% LAD occlusion. When this was submitted to this journal, the reviewer's response said, the NSTEMI paradigm does not miss OMI. The NSTEMI paradigm identifies the OMI by troponin, just not immediately, which is why it portends a poor prognosis. So the response to this reviewer was this. Missed OMI means that STEMI criteria do not detect OMI early enough, leading to a delay in the identification of OMI and therefore a missed opportunity for timely reperfusion. In the context of STEMI, it is widely recognized that a delay in recognition of STEMI until 24 hours is a miss. There is no confusion about that, and there cannot be any confusion about a missed STEMI negative OMI. Both situations are easily understood as a miss. The pathology we were looking for, OMI, on the surrogate test, ECG, was missed, and only discovered later when it was too late to achieve the full benefit that was possible for that patient. If you were to suffer a complete LAD occlusion, putting a large mass of myocardium at risk, but never manifested STEMI criteria, and you were required to wait 24 hours to get an intervention, at which time very little benefit is to be had, with subsequent loss of all that myocardium, then you would have to say that OMI was missed by the STEMI criteria. Conclusion, the STEMI-NonSTEMI dichotomy fails us. It was never evidence-based to begin with, and yet has become a belief system defended at all costs. The feature of a test should not define the pathology. OMI-NOMI is based on pathophysiology. Many features other than ST elevation help to diagnose or exclude OMI. Other modalities are often necessary. Pretest probability, especially chest discomfort, is important. Biomarkers, echo, CT coronary angiography, and angiography itself are important adjuncts. ACS with refractory ischemia needs intervention. Much future research is needed. Again, I'd like to thank the Society and all my colleagues. Thank you for inviting me.